We have a few that we're going to review. Ann will stay up here. Also joining us are Kathy Roby, who presented this morning. Jen Pettis will be back up, as will Joan Proctor, who's the coordinator at CMS. As they gather, I'll go ahead and read the first. Is the other follow-up used for risk adjustment? And the response provided is no, other follow-up is not used for risk adjustment. Only the SOC rock is used for risk adjustment. Next question, are star ratings calculated from each quality episode, SOC to rock and rock to discharge, or from the time of SOC to the final discharge of the episode? The question is, are star ratings calculated from each episode, SOC to rock and rock to discharge, or from the time of SOC to the final discharge of the episode?
I'm going to go ahead and wing it off here. Basically, for this question, they're calculated from start of care to transfer, or from start of care to discharge, or from resumption of care to transfer, or resumption of care to discharge. So, that answers your question.
What is the best way to be compliant with transfers to inpatient acute facility when unsure if the patient is observation or a true admission to an inpatient facility?
When a home health patient goes to an inpatient facility, the home health agency should make efforts to communicate with the facility to determine the patient's status, such as if the patient is admitted as an inpatient or an observation status. When appropriate, the relevant Oasis data collection should occur based on the information available to the agency at the time of transfer assessment.
Slide 57 references the home health agency questions and answers. My question is as follows, or the submitters. When is January 2017 and April 2017 question and answers coming out? This is of great concern that Medicare has not completed them or offer home health agencies to ask and receive answers back. Running a company in multiple states, we rely on the opportunity to ask, receive clarification, and learn what we are to do to stay within the regulations. This is especially true right now as there are new conditions of participation. Agencies need to have the questions and answers up to date so we can follow regulation, report correct data to CMS, and have a proper QRP. When will agencies receive a question and answer for January and April 2017?
Hi, I'm going to try to not read off the paper to you because I know that's probably annoying, but the bottom line of the answer is that unfortunately the Oasis questions that used to be posted are no longer available under a support contract through CMS. So we did publish something in October of 2016 that supports the, and that's on the CUTSO website, that supports the questions and answers, and we finalized that in support of Oasis C2. So as we go through the process of updating and each other changes to Oasis, we will continue to look for opportunities for where those questions and answers need to be updated. However, there's not a formal process and a contract in place to support this activity. However, CMS continues to have internal conversations about how we can best fulfill this. The one thing two things I can point out to you, you've got your Oasis education coordinators out there, and they're an available resource to you, and they often come to us with questions. The other thing is that in a failure to be able to answer your questions, I may have to redirect you to Peggy Wilkerson, who works as the manager in that area. That's usually my last resource when I'm unable to get an answer for you. Thank you.
This is the last question that was submitted that has a prepared response. Is there a plan to address all the statistically topped out quality measures that are impacting home health agency star rankings? Patients are used to seeing 5 stars as good. If the statistical data continues to rise rapidly, such as influenza vaccination requiring 100% to achieve a 5-star rating, how does a home health agency truly report 100%? Is this truly accurate data being submitted in the QRP? Is there other ways to rate home health agencies? Is there a way to have a star rating that is more familiar to patients like hospitals, SNFs, etc.? Why is it necessary to use a bell curve? Does it matter that more than 5% of home health agencies become 5-star? I was incorrect when I stated it was the wrong question. It was the wrong, last question. It was the last set of questions.
Thanks. Here's what I can say about that. We actually, I think in February, we did an open door forum where we announced some changes that we were considering to the quality of patient care ratings. And of course, there are new measures being brought on that are sort of mandated by Impact Act, and we're working with those. So it's a evolving process. The home health star ratings and the quality of patient care is not a stagnant process. We are aware that there are measures that top out, and as we identify new measures that can replace those, we do a refinement process. And I think we got public feedback recently on that quality of patient care star rating. So I really want folks to understand that this is not something that is stagnant, and that we are always welcome in ways to refine our process.
That was Joan Proctor, who you've been hearing from. Any other questions for Joan, Jen, Kathy, or Ann? A microphone, please. Trying to tell if it's there.
This question for Mrs. Spinard. You did mention something about consistency. When we have a patient with pressure ulcer, and we send the nurse the first day to do the admission, and for some reason she cannot evaluate this pressure ulcer, you have on Oasis, you have the start of care, and you have also the date for completion of Oasis. What is wrong if I send the nurse, like in another day or after 1 day or 2, to complete her assessment and find out if she find out that the pressure ulcer she can evaluate? I think that would be better for the agency, because when you do your billing, you also have to put for the non-routine supplies, so you can bill for the wound care supplies, and at the same time, what is wrong in that procedure?
So what we have determined, what a CMS has given guidance is that for consistency, because around the Impact Act, we're trying to have consistency across all of the post-acute care providers, that it's the first time that you assess the skin that whatever that assessment is what you code on the Oasis. Now, for example, if someone codes something on the Oasis as a stage 2, and then in their clinical note, you're reviewing that, let's say it's a new nurse, and you're reviewing it, and they're describing some slough, they still can view it, but they're describing some slough in that wound, what does that tell you? It tells you that That initial assessment as a coded as a 2 was never a 2 at that point. It was a stage 3, right? Because you can't have slough in a stage 2. This idea has come up, this question has come up, and I think question has been answered in the past, the last training that we did. The same idea around what if they assess it as a stage 2 and it's a stage 3, or 3 and it goes to 4, and around billing for supplies. I'm not the billing expert, nor I don't think any of us are going to talk about billing here, but for consistency's sake, what we're asking and what they're requiring is the first assessment that you do, whatever you assess the wounds to be at that first initial assessment, even though you have a 5-day window, that it's that initial assessment is the requirement.
But what is the value of the item that says the date of completion of Oasis? Why we have this item?
So again, for the Impact Act, we're trying to take a measure that's being used across all post-acute providers. And, you know, we have skilled nursing, we had inpatient rehab facilities, we have PACs, and they have varying assessment timeframes. What we're trying to do is the initial skin assessment as being the point of time so that we're not having variation between home health and the other PAC providers. I don't know, Joan, is there anything else that you wanted to add to that?
Does that make sense, guys?
We have dealt with that similar type of feedback in the last training, and we have consulted with our clinicians, and that is our consistent policy in terms of coding guidance for how that is to be completed.
Okay, I'm sorry. I'm not trying to argue with you, but it doesn't make sense that I have an item says date Oasis completion. So it means I have this window to complete my Oasis assessment. So I should take advantage of this and complete my Oasis in the 5 days, and that will help me to financially be able to bill Medicare the right, codes for the non-routine supplies. Otherwise, I'm losing money. So think about it. Thank you.
You're welcome.
Thank you. We have another question that Kathy will take. A patient has both skilled nurse and physical therapy. Skilled nurse visit to discharge, physical therapy to continue. Question 1, who will do Oasis? Question 2, last skilled nurse visit, does it have to be an RN?
When you have both disciplines in the case, and skilled nursing completes their plan, the case remains open and the physical therapy services continue, you are not completing the discharge Oasis at the time that the nurse finishes. So the nurse would write a discharge summary indicating that her plan of care has been accomplished and that the physical therapist is continuing. When the physical therapist is finished, then the episode is finished, then the therapist can, in fact, complete the discharge Oasis. That does presume that you are providing training and competency, including inter-rater reliability, for both nursing and physical therapy staff. If you are going to expect them, and they, in fact, should be expected to complete that assessment, then you need to be sure that you're also accomplishing that. In terms of the last skilled nursing visit, if you are completing a visit where you are doing an assessment to determine that, yes, this patient is goal met for nursing, then by definition of the scope of practice, this would need to be an RN, because in the scope of practice for an LPN, they do not assess. They observe and gather data. They do not assess. So to answer that question, if you are doing an assessment to determine whether or not the plan of care goals are met, then it clearly needs to be, by definition, an RN.
Thank you, Kathy. So we mentioned this morning this is a 2-day training, and while this concludes the face-to-face portion of day 1, it's a 2-day training, and there is homework. So if you could please think through your experiences based on the action plan that's being used, and give special consideration to any challenges or best practices that you saw or faced during implementation, and talk through that with your colleagues over dinner. That's how we'll be starting in the morning. There was one pair of eyeglasses found with a black plastic frame. They're at the back presenter's table. If they're yours, we will reconvene tomorrow promptly 8:30 a.m. Thank you very much.